Hi, I'm Dr. Ashwin Krishnan, an Associate Professor of Medicine at Massachusetts General Hospital and Harvard Medical School. And today I'll be walking you through microbiome-based biomarkers. The objectives we want to cover over the next 15 minutes or so is 1. We want to examine data that defines the predictive value of the microbiome in defining disease outcomes in inflammatory bowel diseases. And then secondly, we want to examine the pros and cons of microbial markers as a therapeutic target for IBD and to explore how that would potentially serve as a treatment endpoint. Before we get started, I think we need to be clear in what we are trying to predict. And there are a number of different questions that we may be trying to answer. First, we may be wanting to predict whether someone is going on to develop clinically overt IBD from a state of health. We then may want to predict if they already have Crohn's disease or ulcerative colitis, whether microbiome-based biomarkers can be used to predict complications. And then if we are starting patients on treatment with the goal of preventing those complications, we also may need to use microbiome-based biomarkers for predicting therapeutic response to individual treatments and to monitor response to continued use of those treatments. So when we're trying to use microbiome-based biomarkers, I think we want to be clear which of these goals we are trying to achieve, as there may be some common factors, but also differences in which signatures are relevant for which outcome. Before we sort of look at the data on microbiome-based biomarkers, let's first see how the microbiome biomarkers, whether in stool or mucosa, conceptually map against either blood or urine biomarkers, which are the other two biomarker compartments that we use. In terms of invasiveness, clearly stool microbiome is less invasive than any of the other tools except for urine, because it doesn't need a blood draw. On the other hand, if we are looking at microbiome-based biomarkers in the mucosa, that frequently requires an invasive procedure. In terms of specificity to gut inflammation, clearly microbiome-based biomarkers, whether it's mucosal or stool, are substantially more specific, directly reflecting what is happening in the intestinal compartment, compared to signatures that one may use from blood and urine, which are broadly non-specific and could be seen in a variety of inflammatory states. In terms of sensitivity to external influences, including diet and environment, microbiome-based biomarkers are significantly more labile than blood or urine biomarkers because they are at the point of effect of diet and various environmental factors. The three questions that we want to answer when we are considering the microbiome as a treatment target or as a biomarker is 1. Does microbiome correlate with active inflammation? 2. Are changes observed in the microbiome dynamic and responsive to changes in inflammatory status? And 3. Can the microbiome predict future disease outcomes? Because an important role of a biomarker is not just to cross-sectionally be associated with something bad happening, but actually look ahead and see if microbiome can predict factors or events such as remission versus relapse or disease progression. So let's look at some data in support for the use of microbiome for each of these three endpoints. To answer the first question for whether there are distinct microbial signatures associated with active inflammation in IBD, we can look at some elegant prospective cohort studies that have looked at this question. The risk cohort is a pediatric inception cohort that included about 450 children who were newly diagnosed with Crohn's disease and about 200 controls. And what they found was that there were clear microbial signatures or biomarkers that differed between Crohn's and ulcerative colitis. And I've demonstrated here what they found in terms of microbial species that are both decreased in Crohn's disease and those that are increased, highlighted in green and red respectively. For examples, you have Fusobacterium, Billionella, and Escherichia increased in Crohn's disease. On the other hand, you have some Lactobacillus, Pseudoella, Faecalibacterium, and Ruminococcus decreased in Crohn's disease. Again, this is at the species level. And what they showed was that this broad microbial dysbiosis correlated inversely with diversity of microbiota, such that the more dysbiosis was observed in Crohn's, there was less diversity in the fecal microbiome. And importantly, this dysbiosis correlated with disease activity. So the risk cohort mapped disease activity using a term called a pediatric Crohn's disease activity index and showed that with higher PCDAI scores, the dysbiosis was greater and that your microbial diversity was less. A similar observation was also made in the PROTECT cohort, which was an inception cohort of children newly diagnosed with ulcerative colitis. So among their final data set, which included 386 children with newly diagnosed ulcerative colitis, there are multiple microbial features that correlated with disease severity and disease activity. You see here the fold change across a spectrum of microbial OTUs that are differential between mild to moderate disease or mild to severe disease, highlighted in orange and red respectively. For example, highlighting here, Mulinella dispar was significantly higher in abundance in severe disease compared to moderate, compared to mild, demonstrating a nice dose response curve. So together, these two cohorts give us a good sense that at least cross-sectionally, there's a different microbial signature associated with active disease in both Crohn's and ulcerative colitis. In terms of the responsiveness of the microbiome to changes in inflammatory status, the best support for this comes from the very elegant HMP2 cohort, which was published in Nature a couple of years ago, where the investigators followed 132 subjects with biweekly samples for 1 year, with careful profile of the microbiome and disease activity states. And what they found was that people with inflammatory bowel disease demonstrated periods of dysbiosis at a median interval of about 17 weeks between these episodes. And importantly, these flares of dysbiosis correlated with blooms of pro-inflammatory phyla, depletion of anti-inflammatory phyla, and depletion of fecal short-chain fatty acids that we recognize for their anti-inflammatory activity. For example, you can very nicely see that there is an increase in abundance of Ruminococcus navis, which is associated with inflammation, and increased abundance of Escherichia that also correlates with these blooms of dysbiosis, and these species have been linked directly to inflammation. On the other hand, there's decrease or depletion of bacteria such as Faecalibacterium, Plasmidii, and Rospiria that have been inversely associated with inflammation. In addition, what the investigators very nicely showed was that this increasing dysbiosis, which they mapped using a dysbiosis score, correlated with fecal calprotectin, such that a greater degree of dysbiosis, particularly in Crohn's disease, was associated with increasing fecal calprotectin values and vice versa. In terms of predicting other outcomes and the relevance of microbiome as a biomarker for those outcomes, a prospective study of 164 patients with IBD who were in endoscopic remission at the time of sampling showed that if you look at the outcome of relapse at 1 year, there are clear microbial signatures that can predict this relapse outcome. For example, an increased abundance of proteobacteria and fusobacteria was noted in individuals who relapsed when compared to those who did not. Again, we're looking into the future, so samples were taken when they were in remission, and we're looking ahead for 2 years after sampling to see if they relapsed. And it shows that even at the time of endoscopic remission, changes in your microbial composition at either the phyla, species level correlated or predicted this relapse occurring. For example, lactose ratio was significantly differently distributed at remission status in those who subsequently relapsed compared to those who did not. A similar observation was noted in this study where they took patients who were in endoscopic remission on infliximab therapy and stopped treatment, and they showed similarly that a depletion of Faecalibacterium plasmidii And the lower rate of bacterialities predicted relapse independent of inflammatory status at the time of therapy cessation. A similar observation was also made in the postoperative Crohn's disease cohort, which is another exciting model to look for relapse. In this very elegant French study that did 16S sequencing and metagenomics in 200 patients with Crohn's disease undergoing ileal resection, showed that using microbial signatures present at the time of resection, you can clearly identify which patients are going to have endoscopic recurrence, with an area under the curve of 97% in their entire population and about 80% in their validation cohort, showing that if you have sort of a depletion of ruminococcus, you're less likely to relapse. On the other hand, if you have an increase in abundance of ruminococcus navis, increase in abundance of certain streptococcus and gamma proteobacteria, you are more likely to have endoscopic recurrence at 6 months. And so together, these three pieces of data highlight the utility of microbial endpoints in predicting either future relapse states, relapse after therapy cessation, or relapse after surgical remission. Microbial data can also be used to predict progression, as highlighted in this analysis from the risk cohort, where the presence of certain genera in either the mucosa or in the stool predicted the development of stricturing or penetrating complications. And the use of the microbiome as a biomarker can also be predicted or can also be derived from studies looking at the role of the microbiome in predicting response to treatment. In this study that's now about 6 years old, but was really an important study that came out at that time, showed that diversity of the microbiota at the time of anti-TNF initiation, or the similarity to the control microbiome, predicted disease outcomes at 3 months after therapy initiation, and disease outcome in this study was assessed using calprotectin. A similar finding was observed in patients who were initiating vedolizumab, where the abundance of butyrate-producing phyla, either Burkholderia or Roseburia immunolivorans, at baseline at therapy initiation significantly predicted clinical response at 3 months. And what the study also showed was that a microbiome-based model, which was highlighted here in the purple line using the term VedoNet, had a much better area under the curve or accuracy in predicting therapy response in comparison to a clinical model, which is highlighted in blue, which had an area under the curve of only 0.61. So again, this highlights the importance and relevance of microbiome-based biomarkers in predicting clinical outcomes. In terms of stool-based biomarkers, we're not restricted to just microbiome, but potentially metabolome as well, which reflects the functional impact of the microbiome. And what this showed was that the microbiome-derived metabolome predicted reasonably well in differentiating active disease from inactive disease in ulcerative colitis, and in identifying ulcerative colitis compared to healthy controls. So in terms of the three questions that we wanted to address with this talk, does the microbiome correlate with active inflammation? Is it dynamic and responsive to changes in inflammatory status? And can the microbiome predict future disease outcomes? I think we have seen some bits of evidence, again, not the entirety of evidence, but some bits of evidence suggesting that the answer to all these questions is yes. Then, from a practical matter, can the microbiome really be a therapeutic target or be used as a biomarker? And for that, there are many pros, as we saw. The microbiome is at the site of action, it's dynamic, and it's mechanistically relevant. All of these features make it very attractive. But at the same time, there are some important cons. The microbiome is dynamic and ever-changing in response to environmental stimuli, and so is the timing and assessment of these covariates is important in interpreting the microbiome, which makes it logistically more challenging than other biomarkers. The microbiome is also somewhat challenging to sample in that it needs either stool or mucosal biopsies, which are both either inconvenient or expensive. The microbiome is expensive to profile at high resolution, and at high throughput and with rapid return of results on an individual patient level, which is all a challenge in the practical implementation of it as a biomarker. So what do we need more of towards developing these microbiome biomarkers? We need more data. And for that, there needs to be consistency across studies to define the target. And for these, there needs to be homogeneous patient populations, similar, robustly defined and objective and relevant outcomes that are consistent across studies that will let us pick the species or strains that are of most relevance, and adjustment for relevant covariates uniformly across studies. We need high throughput, inexpensive sequencing with rapid turnaround for easy implementation in practice. For example, there have been advances done in fields such as paper-based diagnostics that may help us achieve this. And finally, you need interventional studies that confirm the value and utility of microbiome-based biomarkers in serving as a target for translating better outcomes from our treatment. So I'd like to thank you all for your attention during this talk, and I look forward to engaging with you during the panel discussion. Thank you.